Hi, everybody. I am Dr. Diane from the Research and Scholarship Collaborative. Welcome. We are very pleased today to have Dr. Gudavalli for our Lunch and Learn today. Dr. Gudavalli is a teaching and research faculty member at the Keiser University College of Chiropractic Medicine, where he specializes in spine biomechanics, low back pain, and neck pain research. He holds a PhD in engineering biomechanics from the University of Cincinnati and has received multiple NIH research grants, published extensively in international journals, and presented his work at scientific conferences worldwide. We are very happy and pleased to welcome Dr. Gudavalli and eager to be present in sharing his knowledge and hearing his knowledge. So welcome, Dr. Gudavalli. I will hand this over to you now and definitely be enjoying this presentation. Thank you so much for being here.
Thank you, Dr. Diane, for giving me this opportunity. Thank you all for attending this session. This is a research study. We did it at Keiser University, College of Chiropractic Medicine. And it is a small pilot study. It is accepted for presentation at the Association of Chiropractic Colleges Research Agenda Conference to be held in the end of this month, March 2026, in Kansas City, Kansas. And my co-authors are Dr. Cruz. He's also a research faculty, teaching research and clinical faculty too. He does all the things. Then Dr. White is with Miami VA Medical Center, and Dr. Ryder with the Southeastern College. The title of this is Ultrasound Evaluation of Spinous Process Separation Distance during the different traction forces in the lumbar spine in a prone position. Low back pain, in particular, spinal pain, is a major health problem. It's a major disability among, and 80% of the population at one time or another experience low back pain. So, and then chiropractors treat low back pain. Even American College of Chiropractic Physicians, they recommend spinal manipulation. Chiropractors deliver they are the most qualified in delivering spinal manipulation, and they are the ones most often sought for as a conservative treatment compared to pharmaceutical treatments. And when they are assessing the patients, definitely the clinical guidelines they use. In addition to that, they will use imaging modalities to see any underlying pathologies and all. So when you are using imaging, there are several types of X-ray. X-ray imaging is radiography is used very often. Then CT, MRI, and then the ultrasound. The advantages of ultrasound are it is non-invasive, no ionizing radiation. It is less expensive compared to MRI and CT, and also it is portable and easily accessible. In a short time, you can get the images. And real-time, you can see the real-time images. Ultrasound is a versatile, non-ionizing imaging modality across used in medical specialties. And in its application in the spine is evolving. So this is where we the little bit of innovation for us is measuring what is happening when you are giving a treatment in real time. That is the innovation in our project. It's a pilot project. We need to do. This is a line of investigation. We want to continue along this line. Unlike radiography and computed tomography, it does not expose patients to ionizing radiation. Ultrasound is also widely available and cost-effective and portable too. Like MRI and CT are not portable. So the MRI and CT, they give very good images, but they are very expensive, time-consuming, and the patient has to lie on the machine for a longer time. And there may be some contraindications for doing the MRI. You should not have any metals in the body. So ultrasound is definitely so safe and inexpensive and fast, and it is being widely used in clinically now. But we want to take it in the research, and we have several researchers, and we also did our own as part of this research, the reliability of the measuring the spinous process distance separation. And we found it to be very excellent reliability. And then the idea is we are trying to use is, we know the spinal manipulation, a lot of randomized clinical trials, they have demonstrated that clinically effective. But the mechanistic approaches, why this is working when manipulation, still there's a lot of gaps on that mechanistic approach. So, but the theory is they are trying to create the hypomobile segments of the spine. Manipulation improves the mobility in the spinal segment, improve the nutrient flow to the disc, and then separates the facet gapping. Those are some of the things, theoretical mechanisms, and then linking it to the brain imaging. That is one of the future goals we have. Looking at this, first we want to look at the movement in the spine when you are doing this manipulation, and then how that correlates clinically and the brain pathways. That is a long-term goal. So understanding the mechanistic approach, we started doing this, measuring the separation distance between the spinous processes. So both spinal manipulation and mobilization, they are found to be very effective in the clinical, improving the patient's pain and function. And then there are some few studies, different levels of force have a different effect on the clinical improvements. So how much force to apply is one of the NIH scientists, the NIH priority is to find out, optimize this, the delivery of the forces to get a better clinical outcomes. So along that line, we did some clinical studies, then we want to extend this to mechanistic and clinical combined translational studies. So in that sense, the present study we did is along that line. So I did one study, it was published for the neck pain, low force, medium force, and high force. Medium and high force did equally good in improving the clinical symptoms of the neck pain patients, and but they did better than the low force. So there is an optimal range of force that can be used to get a better clinical outcomes, but does that also can be find out in a mechanistic approach and correlate with the clinical outcomes. That is one of the priorities of research from NIH point of view too. And also there are the animal studies have shown the applying traction has regeneration of and repair of the degenerated intervertebral discs. Then also some randomized clinical trials. Some of them have the low force and high force both have some value. Low force seems to relieve pain. Higher forces will increase the reducing the disability, so improve the function. So flexion distraction or traction based studies are one of the things that we are focusing quite a bit of research on that. It is a low force and gently applied technique compared to other forms of spinal manipulation, and it is widely used. We did several clinical trials that flexion distraction is very good for radiating patients, the sciatica type of patients, but we have not optimized the force. We have not done any research along that line in the low back pain from our group. So we want to do along that line, and we have demonstrated some changes in the intradiscal pressure, decrease in the intradiscal pressure, opening of the intervertebral foramina and cadaver studies. So now we are trying to extend this to in vivo studies. In vivo studies has much more clinical application compared to cadaver studies. And they also did some studies, other researchers have studied the effects on the biochemistry of the disc and all, and they are found to be favorable to the spinal manipulation. And the objective of this particular study, even though it is a pilot study, is to apply different forces of traction, like 4 pounds, from 4 pounds to 25 pounds, 4, 8, 12, and 25 pounds. That is around 17.8 newtons to 111.2 newtons. This is a descriptive cross-sectional study, and this was done in 2022, the June to August of 2022, done at the College of Chiropractic Medicine at the Keiser University. And the study was approved by the Keiser University Institutional Review Board. And we took the recruitment and participants in this study are convenient sample of generally healthy volunteers, mostly both genders and ethnicities, and age 21 years or older. Most of them are students and some employees. And they used announcements and flyers to recruited these 30 participants. And exclusion criteria, if anyone is pregnant, we excluded them, and anyone who cannot lie prone for the duration of the procedure. It's only around 10 to 15 minutes maximum total data collection time. And any discomfort experienced during the procedure, but nobody experienced, but that is one of the exclusion criteria. And all the participants provided written informed consent after explaining about the details of the study. And ultrasound, we use the GE Logic P9, GE Healthcare, and to obtain images of the spinous process at L3, L4, L4, L5, and L5S1. These are the regions most often treated in the low back pain patients. So that is why we chose this lower lumbar spine. And using a curvilinear transducer, measurements were recorded with the software installed in the ultrasound unit, and the distances between the most dorsal aspects of the spinous process at L3, L4, L5 were recorded, and only one ultrasonographer obtained and recorded the measurements. That is because the pilot study, we were able to do it with one ultrasound. Ideally, we want to generalize. We need to go have more than one. So this is where the patient is lying prone, and this was traction force stabilized at the upper thoracic spine, was stabilized, and the traction is applied through the table, moving back and forth along the long axis of the spine. And the ultrasound images are captured using the GE ultrasound unit. And the sonographer has identified the most prominent spinous process tips, L3, L4, L5, S1, and then measure the distances. And after applying 4 pounds, 8 pounds, 12 pounds, and 25 pounds, those distances were measured again. So total of 30 participants, 16 male and 14 female, they went through this, and the characteristics are age, mean age 32.5, mean weight 69.2 kg, height, mean height 169, and BMI, these are very healthy, BMI 23.9, and a younger population overall. Well, here is that we plotted the BMI versus the separation distance. It is not strongly correlated, but it's fairly correlated. R square equal to close to 0.6. So that is so BMI has some fairly correlated with the separation distance. And here is the graphs for males versus females and different force level. As the force is increased, you can see there is a non-linear relationship. And the females are slightly more than in the higher force range, but there's not a big difference. We did not find any differences when we averaged those. And this for L3, L4. Then L4, L5, same thing, males versus female. But there is, as the force is increased, yes, separation distance increased. It's a non-linear fashion. At the higher range, females have a little bit more. And that is also observed not from the ultrasound measurements in general. Females seem to have a more flexibility in the sagittal plane, that is the frontal plane too, sagittal plane, bending forward, backward. So that correlates with this. And L5S1, similar trends, males versus females. Females were slightly more, but not big difference. So as the force is increased, the distance is increased, separation distance is increased. So this may provide, if you combine this information design some clinical studies. Can we optimize these forces to get a better clinical and also pain pathways by also measuring the brain imaging? That is future goals. Conclusion, this small study on healthy volunteers demonstrates traction forces creates separation of spinous process in a non-linear fashion with increasing forces. Obviously, we have to do on low back pain patients with enough sample size and determine if the separation distance are correlated with the clinical outcome measures. And these are all the references we used when we are preparing this. And this is where we want to go for next is on a clinical population, low back pain patients, and then try to do the brain imaging. If we can do the brain imaging and also see if we can also see some the inflammatory markers also, and we are collaborating with some CMCC, Canadian Memorial Chiropractic College, designing a study on inflammatory markers during this Cox flexion distraction procedure. So this is where we just focused today. I just focused only on one small study along this line of investigation. We are waiting to design future studies. So now open for any comments, suggestions, questions, and answers. And this will be presented in the March 25th to 28th. The conference is 26th to 28th. So this will be presented there.
Thank you so much, Dr. Gudavalli. So we are open to questions, comments, thoughts for Dr. Gudavalli.
And Dr. Cruz is also in the.
Oh, good. And for Dr. Cruz.
He can address any clinical questions.
Yeah, or Dr. Cruz, if you want to chime in on anything, now's your chance.
There we go. Okay. No, it was a very exciting study, and because we know what we find clinically with our treatments, but the biomechanical reasoning, behind it just hasn't been documented well. So this is a good study for the various loads of traction. We also published one that actually used flexion distraction, which is a very specific protocol. Had that published, and that came out nice. Also found a decrease in opioid use in actual patients who had surgery with this treatment. So we're hoping these studies are all springboards for much larger studies. And hopefully by the end of this week, we'll have another paper accepted on extrapolating the size of the spinal canal and osteoligamentous canal based on the separation of the spinous process measured by the ultrasound and correlated with lateral lumbar x-rays taken by our
Dr. Gregory.
Dr. Gregory here, on campus. So it was nice to use different groups and departments, and we're moving forward.
You also want to talk about the University of Pittsburgh? Not yet.
I can. The press release is out, is getting ready. Dr. Diana, I'll be sending you that as soon as Dr. Illis approves it. But they had a $6.4 million NIH grant, and we applied, and we are now getting assistance from them from the grant. We have a training session today again. They'll help us with writing and IRB, applications and references and, biostatistics is the big one we're looking for. So I will be getting you that press release as soon as Dr. Illis approves it, which should be today, I hope.
That's amazing. That sounds great. I look forward to seeing that. You do have a question from Dr. Farrell.
Yes, Doc.
This may be totally unrelated, but have you ever heard of a syndrome called flat back syndrome?
Flat back syndrome. Dr.
I mean,
Cruz.
yes, we've heard of it. It's just basically a loss of the lumbar lordosis, I think, or unless it's a thoracic issue, but I'd have to know a little bit more.
Yeah, the cervical spine does happen. They lose the curvature. Probably that is very common. Losing the curvature in the cervical spine is very common.
Okay.
Restoring the curvatures biomechanically, curvatures have a function. There are two functions. One is shock absorption. When you are walking, if you have the curvatures in the spine, they absorb the shock. And also when the balance, when somebody loses balance, the curvatures will protect you to a certain extent. It's not completely. So losing the curvature is not a good sign. So if the curvatures can be restored by doing some exercises or braces or in addition to chiropractic treatment, that should be done. Yes.
So it can be treated.
It can be treated. There are two types. One is what they call is fixed curvatures, fixed deformities of the curvature. That cannot be corrected, but that can be prevented further deteriorating. Whereas flexible curvature effects, that can be treated. The chiropractor can assess and biomechanically assess, and by prescribing exercises in addition to chiropractic treatments, that can be corrected. Whereas the fixed problems, they can only be prevented further deteriorating.
Okay. Well, thank you very much.
Interesting. Okay. Any other questions? While you are thinking of questions, I'm going to post the survey for today. When you go in to complete the survey for your certificate, the correct answer will have to do with next week's presentation, which is also a lunch and learn, having to do with exercise science and sports management, which will be exciting as well. And yes, so we still have some time for questions. If you guys have any or discussion, and I'm really looking forward to hearing more about what's next. And you guys have a lot of exciting things happening. So I know that you guys are very busy. I see, a lot coming through in the IRB end. So I get to see things before they are public. So I feel very privy to that. And it's nice to see it on this end as well, once you completed it. If you don't have any more questions, we can finish up, and I'm sure that Dr. Gudavalli and Dr. Cruz would be happy to hear from you if you do think of anything, and we will stay tuned for the upcoming announcement that will be happening soon on this upcoming research and grant, and we look forward to hearing more about that. Thank you so much, Dr. Gudavalli and Dr. Cruz. Oh,
Thank you, Dr. Daniel. Thank you all for attending this session. And you can always give us a feedback in the future too.
yes,
you.
yes. There is a hand raise from Marwa.
Hello, my name is,
Hi.
can you guys hear me?
Yes, yes, we can.
Hi, my name is Marwa. I'm just a pre-med student. So I'm trying to get involved, even just, this is like not related at all, or just at least shadow, I just started my journey. I'm trying to be an MD, God willing. So my question is, how do I get like, even like shadowing on these, research?
Oh, yeah. Please contact us. Which campus are you in?
Jacksonville.
Oh, that's too far. But you can,
Yes.
we can still collaborate on some. We have a research club too here. The reading articles and discuss and if there is an opportunity that on your campus there is something we can collaborate, we can do it.
Okay. All
Yeah.
right. Thank you.
Yeah, also go ahead and take a look at the RSC, and if you haven't already posted, there's a discussion group in there that's open, that's both for faculty and students, and you can post that you're looking for a research opportunity.
All right. Thank you so much.
Okay, good luck. And we do have another hand raised, if I can find it. Blandy Leonard.
We cannot hear you if you are talking.
That Dr. Leonard. Okay, we can't hear you. Oh, you're having difficulty. You want to type if you want to type your question, go ahead and I can read it out. In the meantime, we have another question from Dr. Paez.
Sotomayor, that's fine. Sotomayor, you
Okay,
can do.
Sotomayor. Uh-huh.
Hi, thank you so much, Dr. Gudavalli, for the presentation and everybody else. So I have a question related to the ultrasounds. Do you plan to use any AI components to it? Because I know that for X-rays, they are using AI to analyze very small details. And I'm wondering if in the studies you are contemplating of using AI to analyze the ultrasound.
Yes, we are trying. We are collaborating with somebody. We just wrote one, submitted the manuscript, and they wanted us to do minor revisions. So we are extending from the spinous process to the intervertebral foramina, and then it's too preliminary study, but extend that measurements, and then you trying to use AI component to, if we can, based upon those measurements, does it give any clinical insights? But we have to do studies on patients before we can apply to that. But we are in that direction, yes.
Thank you.
It's too preliminary, but we are in that direction, yeah. Thank you. That is a very good point. You brought it up. Yes, yes.
Thank you. And there was a question from Dr. Leonard. In what ways is this study can be clinically significant in PT rehab?
Dr. Cruz, you want to address that?
Yes, we are. I mean, it's mostly because we're using a special type of traction on the flexion distraction table, which we measured the one with just plain flexion, but then the other one was straight axial distraction or traction at the various loads. And we do have a graph, so we could tell exactly how many pounds we're doing and correlate that to the ultrasound. But it's a pretty specific technique. So I'm not 100% how it would correlate, except for maybe with your traction for PTs.
But there's one difference between this particular traction and in the traction most often used in the PT world, and in this particular technique, traction we use, patient is prone, face down, whereas most of the other traction treatments are supine. So there is that particular difference is there.
Very interesting. Thank you so much. Okay, any last questions? This is the kind of topic that the more we digest it, the more questions there are. So okay.
Very good. The questions will stimulate us too.
Exactly.
Yeah.
Okay. Great. Again, if you think of anything after we sign off, please feel free to reach out to Dr. Gudavalli and Dr. Cruz. They are happy to help you. And again, thank you so much for sharing your knowledge with us, sharing your research with us, and thank you all for attending. If you have research of your own that you would like to share, please reach out to me. We would love to hear from you. This is, a great place to share across campuses. As you can see, we have people from all over, faculty and students. Please visit the RSC and take a look around. And you can also email the RSC at rsc@Keiser University, the same as all of our endings. And I hope to see you again soon. Thank you, guys. Have a great day.
Thank you. Bye.
Thank you.
Thank you.